Oh, hello everyone, and welcome to our Adam Wednesday webinar. This is Denise Wilson, and I'm going to be your host for today's webinar. And happy spring to everybody. So glad to see that that's finally on its way in the door. Our webinar today is going to be on appealing chemotherapy and biological denials, and we have a special presenter today, Carl Harabi, who's going to teach us all about that topic. Okay, you should have a little participation panel that popped up when you joined. You can opt to either call in by selecting phone call, and it'll give you the number to call in, or you can use your computer audio to listen. We do have the handouts already uploaded. If you go to the handouts tab, you can download them from there. That's a PowerPoint presentation for today. Please do your best to download from there if you possibly can. I know sometimes you have problems because you might have pop-ups blocked if you're calling in from work or you're using your work computer. If you absolutely cannot download them from there, you can put a message in the questions and answers area, and our staff put in your email address. Just let them know you need the PowerPoint, and they will email them out to you as soon as they can during the presentation. If you have questions about the content today, and I'm sure you'll have a lot of questions about it, you can submit your questions and comments via the questions panel. So go ahead and put those in there. We're going to go right at probably 50 or 55 minutes. There's a lot of content, but we will try to do our best to answer your questions at the end if we have time left. If not, we do our best to try to send you some answers to your questions individually or post them on our website. We do have free CEUs that are offered to our Adam members only. To obtain those, you have to attend the live webinar for at least 50 minutes. And you have to complete the survey that will pop up automatically for you at the end of the webinar. So please don't leave early because we will be checking that you've been on for 50 minutes to get your CEU. They will be emailed to you, the CEU certificates, usually within a couple of days, 2 or 3 days, we get those out to you because we do check that you have met all the criteria for the CEU. If you're watching this as a recording, CEUs are not available. So we do record these and then we post them to our website at adam.org. Usually within just a couple of days. A disclosure to read: no individuals in a position to control content for this activity have any relevant financial relationships to declare. When you do your CEU survey, you will be prompted to select your desired CEU. So we offer 5 different CEUs from different agencies. You can pick as many of those as you'd like. Now, even if you're not interested in the CEUs, you are welcome to complete the survey because there is a question on there that says, what do you want to hear about in the future? And we do use your feedback to determine what our topics are going to be going forward. So we look at what are we seeing at the company that we work for at PayerWatch, and then also what are you guys asking for that you want to see when it comes to having these ongoing complimentary webinars. Our next webinar is successfully appealing high dollar denials involving NCDs and LCDs, and we do plan to specifically cover TAVR and ICD. During that webinar, we may cover another high dollar NCD, LCD case as well, but those are the 2 that we have planned right now. That's going to be May 3rd at 2 p.m. CEUs for our Adam members only. You can register on our website. We don't have it up on or when I checked a little bit earlier, we didn't have it up on our homepage, but just go to Education, Denial and Appeal Management Webinars, and you can register for that now. So that's open for registration. A little bit about the association. We are the nation's only association that's dedicated to healthcare denial and appeal management. So we started this association. We're coming up on our 3rd anniversary in April. Actually, April 15th, tax day, will be our 3-year anniversary. We're up over 500 members and still growing. And so we are here to help support you who are working in this area, because there really wasn't a lot out there to help those who are fighting denial through the appeal process to become educated, to have resources and support that you need to be successful in this field, and so that was the reason for starting the association. And it was created through a generous support of PayerWatch, which is a company that Carla and I have. Carla's been with them for about 6 years, and I've been with them for about 15 years. We provide appeal services, and we also have software, and we've been instrumental in training really literally thousands of people in denial and appeal management over the 15 years that I've been with the company. And, you know, we really believe in taking our appeals all the way, using a clinical legal approach, and we've done webinars on those in the past, which you can find on our website. And then our software is a leader in the industry in providing service to those providers who are providing healthcare to our members in our community and helping you protect that hard-earned revenue. I do need to read through this disclaimer. I'll try to go kind of quickly, and then we'll get into introductions in the meat of the presentation. Our association, we publish and distribute materials on our website that are created by our members and also invited industry subject matter experts for the benefit of all of our members. And we don't certify that accuracy or authority of those materials are accurate or authoritative. The materials are distributed and presented as research information for you to use in conjunction with your own research and your own independent professional judgment. We claim no liability in relation to the reliance on the content of these materials. The views expressed are the views of the materials authors, do not necessarily represent the views of ADAM. Any references are provided for informational purposes only and do not constitute endorsement of any sources, and there are no conflicts of interest to declare for this presentation. A little bit about me. I've been in healthcare for well over 30 years now. You know, doing bedside care, clinical management, education, compliance, appeal writing. I've authored hundreds and hundreds, probably thousands of appeal letters in my lifetime. I've done hundreds of cases at the administrative law judge level. And today I do mostly a lot of education, a lot of speaking, and managing our association that helps support those of you who are in this industry. And our special presenter today is Carla Haradi. She's the Vice President, PayerWatch Appeal Masters, and she's a registered nurse and has a BSN from University of Pittsburgh, Johnstown. She also has over 30 years of experience in healthcare, including clinical documentation improvement. She started a clinical documentation improvement department at the hospital where she came from. She does have a lot of large background in oncology, which has helped with the development of the content for today. She was a frequent guest speaker at the University of Pittsburgh, Johnstown for many years, and served as a preceptor for nurse practitioner and PharmD students when they started at the University of Pittsburgh. She's been with us since 2016, so going on 7 years. And she has continued to participate and educate clinicians, coders, CDS folks about the medical appeal process. Okay, learning objectives as well. At the conclusion of the webinar, our learning objectives are that you will be able to identify 2 locations in a healthcare system where necessary information to appeal for outpatient chemo and biologicals might be found. You should be able to identify the modifier for drug wastage that's billed on a UB04, and also identify 2 Medicare documentation requirements for administration of chemotherapy and biologicals. And guess what? Those questions will be on your survey at the end. So, Carla, are we starting off with a poll?
We're starting off with a poll. We are.
All right. Do you want me to go ahead and launch it?
Please,
or do you want to talk about it?
No, let's go ahead. Let's go ahead and launch it. I'm interested to see the results, and then we can talk a little bit about it.
Okay. We're going to launch this. We'll leave it open for you for, 30, 45 seconds or a minute. We'll see how Carla, I'm not going to give you keyboard and mouse control just yet until the poll's done.
Okay.
Good. Okay, give you a couple more seconds and then we're going to close it down. Okay. I'm going to close the poll. Let me go ahead and share it with you all. Okay, so we had, Carly, we had 70%. I don't know if you can see the poll results. We had 70% who picked the first answer, verify the medical records, supports the billing. That's why UBO4 is important to review and understand. 18% said pick number 2. I have no idea. Thank you for your honesty. 6% pick number 3 and 6% pick number 4.
Okay, that's really interesting. I kind of expected to see the first answer and the second answer flipped, because that's how I was when I worked in the hospital denials and appeals. I had no idea what a UBO4 was or why it was useful, and it's really useful for when we need to look at these denials for chemo and biologicals. So we are going to talk a little bit about that, but I'm thrilled to see that there are a lot of folks who know more about it than I did back in the day. Looks like my camera flipped. There. Is that better? I can't see myself, so.
I think you might be able to see yourself again once we hide the poll. So, all right. Okay. So, Carla, should I go ahead and hide the poll and continue on?
Yeah.
Okay.
Yeah. Yep.
Okay, there you go. Okay, now I'm going to turn control over to you. Give me just a second, and I'm going to let Carla take it away.
Okay. So, so the right answer is okay. It's not moving, Denise. Oh, here we go. There we go. Okay. To verify that the denied drugs were billed correctly. That is the right answer. And there's a couple reasons we need to do that. And we're going to be talking about that throughout the course of this webinar. But first of all, I think my number one rule whenever I'm appealing or looking at a denial is I never, ever believe that the payer was correct in their assessment. No matter how convincing it sounds, you want to scrutinize every point in the denial, and make sure that every point they make is right. And sometimes they are right. Sometimes we make mistakes. Everybody's human. Sometimes they're wrong. A lot of times they're wrong. And if they are wrong, that should be a main point in your appeal. You want to point out exactly why they were wrong. And if they're right, you might want to consider rebilling if it's applicable, or maybe not appeal at all. So we will be talking about UBO4s, not in a whole lot of detail. I'm not a biller, heaven knows. You know, I'm not here to teach billing. But what we're going to talk about is a little bit of billing, a little bit of clinical, a little bit of math, a little bit of writing. So here we go. But before we start to do that, I do want to say a few words about prevention. One of the goals of ADAM, excuse me, pardon me, doing these webinars and educational sessions is if we can prevent denials in the first place, we want to do that. And I think there is a lot of opportunity when it comes to chemotherapy and biologicals. There's some steps that I believe can be taken to help prevent them before you ever even have to call in the appeal specialist. So let's just take a few slides. Let's just take a look at a few. So we're going to be talking mostly about outpatient chemotherapy. Excuse me. I've had a cold, so please forgive me. We're going to be talking mostly about outpatient chemo and biological denials. And whenever the records, the folks who fulfill the records request, whenever they're fulfilling those records, oftentimes they're very familiar with inpatient records, but not so much for outpatient. So in general, I'm so sorry. In general, reviewers need the reason for the drug, the medical necessity for that drug in the truest, purest sense of the phrase. You need the diagnosis. Is the drug appropriate for the diagnosis? The best place to support the medical necessity for that drug is in the provider's office notes. Most of the time it's going to be an oncology provider, but you want the most recent office note from prior to the administration date. Diagnosis is more than likely there. It needs to be a provider note, an MD, a DO, a nurse practitioner, a PA, a provider who can make a diagnosis. So that is that's one document that you absolutely need. Another document that you need is wherever the patient weight is located, and a current weight, not from 2 years ago or 5 years ago, but the current weight related to the date of service. It might be in that office note. It might be in the order for the chemo. It might be in the nursing intake note. Wherever it is, the reviewer does need that because they will calculate the dose for accuracy. If the dose is ordered like 50, so many milligrams per kilogram, they will check it for accuracy. Something else you need is the signed and dated order for the date, for the drug, for the date of service, or the cycle that the date of service falls into. Now, a cycle, when you're talking about chemotherapy and biologicals, is there's an office visit, and there's often labs that are done ahead of time. And then as long as everything checks out, then the provider orders the chemo for a certain number of times. And it might be after the office visit, come in weekly for 4 weeks. And then they have more blood work done in another office visit. That is one cycle. However many times the chemo or the biological was ordered after that office visit, until they're reevaluated again, and then another set of orders is written. So you might have an order for the drug that says something like, drug A, this dosage, whatever, to be administered weekly times 4, and that's fine. That's absolutely fine. It doesn't have to be a separate one for each day if it's in a cycle. Yes, I talk with my hands. So some other things that you absolutely need to have are the medication administration record, the MAR for the date of service. And this is one of the biggest reasons that I see for denials is because they didn't get a MAR. They got everything else, but they never got a MAR to review. And I do think it's because it might not be where those folks who are looking for the medical record. Oh, there we go. A little better. I think they just don't know where to look, where to go. So the medication administration record can often be found at the place of administration, in the infusion center, in the cancer center, wherever it's being administered, sometimes in the oncologist's office. You need the drug name, the dose, the route, the date, the start time, the stop time, the name and the credentials of the person who administered that drug. Flow sheets are often sent, but flow sheets are not the same as MARs. They don't usually have that same information on them. They do often have the start and stop times if that's not on the medication administration record, but you need the MAR. They need to know where to get it. The other thing that you need is documentation of wastage, if wastage was billed on the UB04. Pharmacy likely has that information because these days, chemotherapy and the biologicals are usually prepared by a pharmacist or maybe a pharmacy tech. On occasion, there can still be an oncology nurse. I've prepared lots of it back in the day, but there could be an oncology nurse or sometimes a physician or another provider that prepares the chemotherapy or the biological, but they still have to document that waste. It will be there somewhere. You might want to check with management at the place of administration for that information. They might even be able to give you a contact, if nothing else. So there again, getting the documents that the reviewer needs to do their job. Otherwise, you will get a denial. What reviewers often receive after requesting medical records for an outpatient chemo data service, unrelated hospital admissions and records, they get the total hip that the patient had done, the operative records from 3 years ago. They get flow sheets, nursing intake information instead of provider progress notes, no wastage documentation, labs and tests and radiology results. They get a lot of things that they just don't need. So you might want to ask yourself or somebody in charge where you work, what medical records are sent in response to records requests. It might be interesting. It might be eye-opening. So it might be something to look at to try to prevent some of these things. All right, now we're going to go into how do we appeal these. We need to look at some definitions first. Chemotherapy, for our purposes, chemical agents used to treat disease. And they're sometimes derived from plants. So I gave some common examples of chemotherapy, but if you're here at this webinar, you've probably heard of most of these. If not all, some of them are quite old. Methotrexate, that's a real old one, but it's used for a lot of things still. Taxol, that happens to be derived from Pacific yew trees, and vincristine comes from Madagascar periwinkle, of all things. Now, biologicals is a bit different. They are derived from living organisms. So some examples of biologicals would be blood products, vaccines, cell therapy. We're not getting into different cell therapies. We only have an hour. That's for a whole other time. Growth factors that oncology patients often need. And there are a lot of other growth factors as well. These are just some samples. Now, what we will be talking about are some monoclonal antibodies. Trastuzumab, pertuzumab, bevacizumab, rituximab, and you notice they all end in MAB. And that's often how you can identify if something is a monoclonal antibody. And sometimes they're called MOABs as well. So these are, just so we're starting from the same place. Just some basic definitions here. The UBO4, because there are some folks out there that don't know what a UBO4 is. It is a bill. It's the claim. It's a billing form that is used. Codes are put on the UBO4 to bill for services that were rendered. And a UBO4 looks something like this, and up at the top you'll have the patient's name. There will be different codes, inpatient, outpatient, the dates of service. They're all up in the top section. Down toward the bottom section, there will be codes for diagnoses, procedures, the DRG, if it's an inpatient stay. But we're going to be looking more at this section that's in the middle. This section is where there are charges made, and this is where the chemotherapy and the biologicals are charged, and this is where you're going to look whenever you're checking to make sure that what was billed is supported by the medical record. Now, a few definitions for some of the things, some of the codes that go on that UBO4. HCPCS, HCPCS, it stands for Healthcare Common Procedure Coding System, standardized codes produced by CMS. An example would be HCPCS J9305. If we would look that up, you would find that that is for Alimta, and also called pemetrexed. And we're going to be talking about where to look these codes up in a couple of minutes. Code modifiers. You'll have your HCPCS code, and then there's another code, letters usually, and that just gives additional information. There are a lot of modifiers that can be used. One you see a lot is JG. It's just an informational code for uses other than ours. But that JW is a very important code to be able to recognize on a UB04, because that means that that code, there's part of a drug was wasted, it was discarded, and it's being billed for, which is appropriate. So just a little more about wastage, because we do see a lot of denials for wastage. If only a partial vial of chemotherapy or a biological is used, and part of it has to be thrown out because most of the time they're not multi-dose vials. You can't use them for another patient, and they actually have to be wasted, discarded. You can still bill for that, but that JW has to be by the bill. You want to be able to pick that out in UB04. JW. Okay, I know this is fuzzy, you can't read it, that's okay, but I'm going to blow this part up. I blew up a little bit of UB04, and we're going to look in detail at that part in the middle. So if you look at a UB04, in that middle part that we talked about, the first column is going to be revenue codes, then a description, then HCPCS codes are in here, service date, service units. This is going to be very important. We're not going to worry about the total charges and the non-covered charges. So if a drug is denied, more than likely with Medicare, you're going to have that, and we're talking mostly Medicare today. You're going to have that HCPCS code on the UB04. So if I look up J9271, I'm going to find that it is an injection, pembrolizumab, and then it's going to say 1 milligram. So let's just break this down just a little bit. When they say injection, as nurses and providers, we often think of injection as being IM or sub-Q. It could be IM or sub-Q, but most of the time they're going to mean IV. It's a vial, and there's liquid in it, liquid medicine, or else there's drug in there that gets reconstituted, so it can be given IV. The 1 milligram, we're going to talk about a long descriptor. When this says injection pembrolizumab 1 milligram, what it means is 1 milligram is 1 service unit. And this is where the billing part of it comes in. So if I'm going to double check the medical record, I can see that 200 service units of pembrolizumab were billed. And it's 1 milligram equals 1 service unit. So I should be able to look in that medical record and see that 200 milligrams of pembrolizumab was given to the patient. Should be a 1-to-1 correlation there, because I don't see JG with this particular code. Or I'm sorry, I don't see JW for this particular code. So that means no wastage was billed. Now, for this particular case, there was another drug that was billed, J9035. And if we look that one up, that's pemetrexed. The long descriptor tells us it's 10 milligrams when we look that up. So that means 10 milligrams of that drug equals 1 service unit. So these are not all the same, but that tells me there were 71 service units that were billed. If there's 10 milligrams to 1 service unit, I should be able to go to the medical record and find 710 milligrams were administered to the patient. And if I look down on this line, the same drug, J9035, but it has a JW. So that means there were 10 service units that were wasted. So I need to find documentation in that medical record that there were 100 milligrams of drug that was discarded. And that's usually going to come from pharmacy. Okay, let's talk about that HCPCS code long description a little bit. In this particular case, we're going to say it was denied because the medical record did not provide sufficient documentation to support the amount of drug billed for HCPCS J9305. So if you do an internet search, and there's a link right here, and there's also a reference page at the end of the PowerPoint and in your slides with this link. And it's best to go to the source. These come from CMS, so it's best to go to CMS. There's a lot of places out there that you can find this information. Personally, I just like to go to the source. So if you go here, you're going to find Excel sheets, a lot of Excel sheets, but they're dated. So you find the ones that are consistent with the date of service for the patient, and then you're going to search in the Excel sheet for the code that was denied. So there can be thousands and thousands of codes in those Excel sheets, but it's really pretty easy to search. So if you don't know how to search in an Excel sheet, it's a quick and easy thing to learn how to do. So when I looked up this code, J9305, then in the spreadsheet, this is what it looked like. HCPCS code J9305. We're not worrying about that. Long description, injection pemetrexed not otherwise specified, 10 milligrams. And the short description, they just have some abbreviations, but it still tells me it's 10 milligrams. So that means 10 milligrams of drug is 1 service unit to be billed. And that's what goes on the UBO4. So this is where you can find that information. Now, there's a lot of required documentation that usually in the Medicare denial letters, they're usually pretty good about telling you what you need. With the commercial ones, sometimes they are, sometimes they aren't. But I want to show you exactly where the guidelines come from. Local coverage article A53778. If you look that up, you're going to find documentation requirements. And one of the first ones, the appropriate code, should be used with the appropriate number of units. And they're referring to the UBO4. So my hint to you, check the long description, just like we talked about. Then upon initiation of the infusion, it's expected that the start time be documented as well as the stop time. So you need the start and the stop time. And most hospitals have that incorporated into how they document the bars these days, but not everybody. So it might be, if you don't, it might be something to look at. The nursing documentation and/or medication administration record should indicate this information and be signed by the appropriate clinical staff. So how's the reviewer going to know if it was appropriate clinical staff? they look at the credentials. And the credentials are much more important than a name. So if you have a medical, or if you have a MAR and there are initials on there, but you don't have the signature part of it, you need to get it, and you need to send that signature page, the signature sheet that contains the credentials, because not everybody who administers drugs in a hospital or an outpatient setting is permitted to administer chemotherapy or biologicals. There has to be specialized training for it, and in most, if not all states, it's going to be at the RN level and above for that. So they're making sure that the right credentials for the person who administered it are there. When requested, excuse me, providers should submit documentation indicating the volume, start and stop times, and infusion rates of any drugs and solution provided. In my experience, they expect it. So I think best practice is just to include that information, give them the order, give them the medical administration record so they can compare, make sure everything matches up. Otherwise, you might lose a level of appeal if they come back after the level 1 and say, okay, you gave us the MAR, but we don't have the order, because that's probably what they're going to do. So best practice, in my opinion, is to include the order so they can compare the order and what was administered. If some of that info is only on a flow sheet, send the flow sheet as well, like start and stop times. If it's not on the MAR, hopefully it's going to be on a flow sheet. You definitely need that. Okay, let's get into some specifics now, some specific things that are denied. MUE, medically unlikely edits. This is the denial usually when there's a dosage that is usually within this many milligrams and this many milligrams, or whatever the unit is, but there's an outlier. And it's just going to kick that claim right out, and they're going to say denied. And there might not even be a human being that even looks at it to see. So you're going to need to support why that particular patient needed usually more than what was expected. And that's often related to the weight of the patient. And there are certainly other reasons, but this is only an hour webinar. So this is what I see the most with the medically unlikely edits. So here's a Medicare case study, our first one. It's a real case, and the denial read that the units of service billed on the UB04 exceeded the allowable MUE. Then it goes on to say, documentation was insufficient to determine the amount of chemotherapy that was administered and wasted. Payment can be made if there's adequate documentation of medical necessity of correctly reported units. So if you scrutinize the denial, one thing you should notice right away, okay, they have a medication administration record, so you don't need to send that again. But what they're looking at, even though they don't come out and say it, they're looking at the number of milligrams billed. 2235 was given, 230 was billed, okay? You would expect the units to be billed would be somewhere around maybe 220, 224. If you recall, it was I think it was 1 milligram was 10 units. So you need to compare that, and then you have to figure out, okay, why is there a discrepancy? Well, I'll bet there was wastage. So they need to look for that. And in this particular case, we were able to get it from the pharmacy. So the rebuttal to this, per the physician's orders and the progress record of, and you always want to make it easy for that reviewer. Tell them what page it's on with what you're sending. 15 milligrams per kilogram was ordered to be given every 2 weeks, and this particular person's weight was 329 pounds. So she was a larger lady. The bevacizumab injection, per the pharmacy record that we were able to get, said exactly the vials that were used, what was administered, and what was wasted. It was great, 2.83%. So that was the summary. Now we also write a justification for appeal. We spell it out. And in this case, do you remember I said appealing these is there's a little bit of math? Well, you need to show your work. So in this particular case, 329 pounds is this many kilograms. The order was for kilograms per milligram, or per 15 milligrams. So you multiply the two, and you got that calculated dose, which is just slightly above what was actually administered, and it was rounded down slightly, and that's very common. That's common practice. Vials of the bevacizumab used were 100 milligrams and 4 ml vials. So if you think about it, to get that dose, they had to use 22 vials to provide 2,200 milligrams, but the dose is 2235, so they needed to use a partial vial to give the complete dose that was ordered. So an additional 35 milligrams had to be used out of an additional vial. So in all, 22 plus a partial vial was used. So if you subtract 35 from 100, that means 65 milligrams were left over and discarded and wasted. What the pharmacy documented was that 2.83% of the drug was wasted, and it all works out because the total amount of drug used and wasted was 2,300 milligrams. And here I'm showing the work. And 65 milligrams divided by 2,300 is 2.826, documented as 2.83%. So you have to show your work. And we won this, by the way. It went to the ALJ level, but the ALJ got it. And this is what the actual documentation from the pharmacy looked like. In their hospital, they called it meta waste or Medicare waste. The description, drug waste, 2.83%. So you have to kind of fill in those blanks and do the math and show your work like you were told in grade school. It works. It works. Here's another example from a different hospital of pharmacy documentation for waste. The dose charged, and the reason was waste. And there again in the appeal, we did the work, and it all matched up. The pharmacists, they know this stuff. They really know it, and sometimes it's just a matter of finding it. And true story, with one of our clients, we had a lot of trouble getting the pharmacy wastage, and finally I tracked it down in a storage facility somewhere miles away from the hospital, but they did track it down, and it will be there. It's just a matter of getting it. We're going to go into some detail now about some of the Medicare requirements and what is in the Medicare letters. We're going to look at a review result letter. It's an actual letter, and kind of break it down a little bit. It looked to me at first, it all looked very intimidating until I started to break it down. And then it wasn't so bad. So they often start with references. And I just highlighted a few here. This is one we already talked about, the HCPCS file that they use. Take a look. If you're involved in denials and appeals for chemo and biologicals, take a look at some of these references. They give very clear instruction on how things are supposed to be done. And I'm a nurse. I'm not a biller. God bless the billers and the coders. But I could understand this. So take a look at it. It's not that bad. Okay, this is from a RAC denial letter. Drugs and biologicals are billed in multiples of the dosage specified in HCPCS code long descriptor. And then it goes on and talks about how you figure, how it's supposed to be. And I just put some notes here. And it's just what we already talked about. The code's long descriptor indicates how the drug is supposed to be billed. And the units billed go on the UB04. Now this part talks about rounding up and rounding down. And this is something that if there's any pharmacists out there or anybody who mixes, you're going to want to pay attention to this, because I think all the pharmacists know that it's okay to round up to the next highest unit. But what we're forgetting sometimes is it also says up to the amount of drug or biological as indicated on the vial or package label. So if you go over that, it's going to get kicked out. It's going to get denied. This, it might be one service unit, but I've seen it recently, and there have been several recently that we were able to claw everything back, and it was thousands and thousands of dollars, except for that one service unit. We couldn't get that, but that's what kicked the whole thing out. So pharmacists, please be careful with that. Okay, you can't exceed the amount on the vial labels, not letters. This paragraph, what this says is also what we talked about already. Got to use that modifier JW on that UB04 to indicate wastage. Very, very, very important to pick that wastage out when you want to appeal. What time is it? Okay, we're getting there. Okay, here's case study 2. The medical record provided does not contain sufficient documentation to support the amount of drug billed for J9312. The documentation submitted did not include a MAR. That was the only reason it didn't include a MAR. So check the UB04 to see what was billed, make sure everything matches. Just like we talked to before, if it doesn't match, consider rebilling if it's possible. If it does match, consider appealing. Assuming what was administered and billed match, if there's specific reasons that they give in that denial, give them what they want. Just give them what they want. In this case, they want the MAR. So let's give them the MAR. And this is a real appeal. This was it. So, this sort of information up atop, the beneficiary name, date of service, that sort of thing. We include that in our appeals. Justification presented to the best cancer center on the state for treatment per the accompanying EMAR on page 22. Make sure that it is on page 22, and you send page 22. Mr. Doe was administered rituximab. It was started. It was stopped. And they didn't ask for all this, but it kind of bulletproofs your case. And it also helps, I think, that to show that you know what you're talking about. You know what the requirements are. The requirements are the med, the route, the dose, what's it mixed in, when was it started, when was it stopped, and the credentials of that person. So this took maybe 10 minutes. It's a pretty good return on investment. Just give them what they want. Make it bulletproof. Let's talk about medical necessity of the drug for a minute. And I know we are starting to run a little short of time here. Medical necessity can mean a lot of different things. It can mean, is it FDA approved for the patient's condition? But it can mean a whole lot of other things that we've already talked about. Also, is it used off-label? Does the medical record support why? Is the dose supported? Is the dose consistent with the package insert? Is the billing for the drug unlikely, which we talked about, the MUE. The Medicare Benefit Policy Manual tells us a little bit about off-label use of drugs and biologicals in an anti-cancer chemotherapeutic regimen. And I'm going to show you an example of this in a minute. Physicians are permitted to use medicines that are prescribed for one thing, or approved for something, but not necessarily approved for what the doctor wants to use it for. But what this tells us is that it can be acceptable under certain conditions. If it's found in compendia or in peer-reviewed medical literature. And I'm going to just show you an example. There we go. Okay, so the Medicare appeal decision denied infliximab for 160 units billed. And it was denied. They said the documentation didn't support the medical necessity of the dosage. It wasn't safe, effective, reasonable, or necessary, not allowable indication for FDA, and also it gave the medically unlikely edit, which not really addressing here because it was exactly the same as what I showed you before. In this particular case, the physician documentation was really, really good. And he wrote, that this particular patient has a severe and uncontrolled case of hidradenitis suppurativa, and we're going to call it HS from here on. Recently, the dosing had been increased, but it was still severe and uncontrolled. They did a trough level. The target was 10, but the trough level was only 1.99. And he went on to explain that could explain the suboptimal response. And then they explained what the plan was. And this poor guy, he also got dialysis 4 times a week. So it was really, really tough getting the right amount of drug in his system to be effective. So we brought all that together. We produced that documentation. We showed that documentation, but then we brought it all together in the justification for appeal. The patient was suffering from HS. It was severe and uncontrolled. He had a previous traumatic response diminished. The trough level was only 1.99 with a target of 10. The physician felt the best option for this particular person was to optimize. And then regarding the dose required, this gentleman weighed 280 pounds. As such, the total dose was much higher than would be expected with somebody with a lower weight. It was in the target drug activity level. And then we went on to explain physicians are permitted to use FDA-approved drugs off-label when there's good reason to do so. Went on to talk about some recent literature that suggests that what the physician did was exactly right for somebody like this patient. And then we show that medical literature. In this case, we don't usually send abstracts, but in this case, the appeal had to go out quickly. We just needed to get it out. So we used an abstract. And another reason was this particular article, you had to pay for it. We don't usually use articles that you have to pay for. But the abstract had fantastic information. It offers the benefit of weight-based dosing. Preliminary data indicates a higher starting dose produced maximal improvement with minimal safety issues. Infliximab may be preferred for patients with moderate to severe HS and high BMI scores. So we don't have the results on this one yet. This was recent, but I'm thinking we're probably going to win this one. So that's how you might look at something like that. Okay, to summarize a little bit of prevention. Prevent them up front if you can. Are the right documents being sent when a records request is made? It's so important. This is high dollar. This is high dollar stuff, especially when they get it over and over and over and over. It's not just a one-time dose. It can be very high dollar. If your process where you work needs improved, you want to get the right people together. Pharmacy for the wastage, so they can tell you where is the wastage documented, and tell them about the, they can't exceed the wastage limit. They can't exceed the limit on the labels. They miss that sometimes. Management of the infusion center or the cancer center or oncologist office, HIM, whoever it is where you work that plays a part in getting the right records. Show them examples of denials. Take out the PHI, but I'm telling you what, that can be eye-opening for these folks. They have no idea that these denials are going on. With the pharmacy, I've been asked several times, well, why do you need that information? Show them the denial. That, oh, okay. Summarizing for appeals very quickly. Be sure that your medical record supports the billing on the UB04. Pick out that wastage, that JW modifier. Know how to look up those drug long descriptions, know what they mean. Show your work. Do that little bit of math. If it's an MUE, look to see if the drug was ordered as milligrams per kilogram, and if the patient's weight BMI is high, give them what they want. Make it as bulletproof as you can. Use peer-reviewed medical literature to support off-label use. Okay, and I don't think we have
right
time for questions and answers.
We don't. We're right up on our time. So we will look at what you guys have entered in your questions in the questions box and do our best, like I said, to gather those together and get some answers that we can post on our website. And so appreciate that. Appreciate your time, Carla. That was actually not as dry as I might have thought it was going to be. It actually was pretty interesting because, as appeal writers, we're charged with appealing sometimes all kinds of denials. And if this isn't your wheelhouse or your background, then this is really helpful information to know how to be successful if you find one of these, thrown on your desk to try to appeal. You may not have the luxury of giving it back to the oncology unit to do that appeal work. It may be something that you end up having to do. So I don't know that I've ever shared this with you, Carla, but I used to teach medical calculations to our nursing students at our local community college. So I just had some horrible flashbacks as we were going through that math.
It's not bad. It's not that bad. It really isn't.
No, it's not bad. That's not bad. That's not like trying to calculate a drip rate on an IV pump. But anyway, thank you everyone for attending. Please fill out your surveys. Please sign up for our May webinar. Thank you, Carla, for presenting today. Everyone have a great rest of the day, great rest of the week. We'll see you in May. Thanks, everyone.
Bye-bye.